I would like to invite the chairpersons for the next session on pulmonary embolism. I request Dr. Subodh Jain sir to kindly proceed on the stage. Sir is a senior physician of repute and an outstanding diabetologist, and he is the past president AMA. I welcome you, sir. Dr. Jyoti Bhushan sir. Sir is senior surgeon and vice president IMA. Sir is director of Puja Hospital. I welcome you, sir. Dr. Brijendra Chaudhary. Sir is senior pulmonologist at TB Hospital, Tilierganj. I welcome you, sir. Kindly take your seats. I now request the chairpersons to kindly introduce the next speaker. Thank you.
Awards in his name, but the most important introduction for us that he has been coming to Allahabad to teach us repeatedly. He is founder MD, Midland Healthcare and Research Center, Lucknow. Current affiliation, Head of Department of Pulmonary Critical Care and Sleep Medicine, Midland Healthcare and Research Center, Lucknow. Founder member, Board of Southeast Asian Academy of Sleep Medicine, ex-president, SEAASM. Welcome, sir.
Thank you. Thank you, Dr. Ashutosh Gupta, for inviting me and giving me this opportunity to share these moments with you. So, I will be talking on the pulmonary embolism, when to suspect, diagnosis, and management. Pulmonary embolism, if you look at the incidence, actually, when I was a student in the medical school, our teachers were saying that probably we are not encountering patients of pulmonary embolism in our clinical practice. That was the scene actually around 40 years back. So, if you look at the incidence, actually this data from the US, 69 per 1 lakh population, about 3 lakh cases occurring annually, and 1 to 2 PE episodes per 1,000, up to 10 per 1,000 in elderly population. So this was the Western data, and we were thinking probably we were not having, but when the autopsy study from the PGI Chandigarh came, they showed that we are equally having this 15.9%, 159 per 1,000 of adult autopsy cases have positive PE. So in that way, that was an eye-opener for all of us actually. And the risk in healthy air travelers is also quite high, especially those who are having the long haul, associated with increased venous thromboembolic risk. Then, if you look at the mortality figures in the myocardial infarction, in the STEMI, there has been a significant decline in mortality since 1995. And it has come down to even less than up to 5% death, and in comparison to what it was around 20%. And in non-STEMI also, there has been a slight, slow, steady, but slower decline. And if you look at the modern therapies and guideline-based care has led to the significant improvement in mortality in the patients with myocardial infarction. But while you are coming to the patient with the pulmonary embolism, the scenario has not changed in last 20 years. In 1999, it was 12.5% mortality, and if you look at the different registry, you can see here, up to this part registry, it is still 10.2%. So mortality figure has not changed for the pulmonary embolism in the last 20 years, although it has significantly improved in the patient with myocardial infarction. If you look at the long-term consequences of the post-PE syndrome, the meta-analysis has shown that 18% patients, they still have the ongoing right ventricular dysfunction, which is persistent. 11% of the moderate to the severe functional impairment, and the 6-minute walk distance is also hampered up to the prolonged time. 24% patients have 30-day all-cause readmissions in patients with pulmonary embolism, in spite of so much of the advancement and management. The long-term recovery after the pulmonary embolism, after the acute submassive pulmonary embolism, there's a death in 3 to 10%, and survival is 90 to 97%. And full recovery is around 96%, and CTEF in around 4% patients. In the acute intermediate risk patient, the death is around 15%, survival around 85%, and although this is the data from the study, they have shown that probably they were not able to calculate the full recovery in how much percent and partial recovery for CTED, chronic thromboembolic disease, and chronic thromboembolic pulmonary hypertension was attributed in around 4%. So what is the management approach of the acute pulmonary embolism? Before that, how you are going to diagnose your patient of pulmonary embolism? First, the most important thing, the clinical symptoms. Patient presenting sudden dyspnea, chest pain, hemoptysis, and at times patient is and severe, basically the hypoxia. There are 4 things which are clinically presented, although Wells score and Geneva score are there just to have a prediction that your patient is suffering from pulmonary embolism. To confirm it, actually, we do the D-dimer test, then we do the transthoracic echo, and then CTPA and the VQ scan. That is how we diagnose the patient of pulmonary embolism. Basically, the acute pulmonary embolism, the management, the systemic approach is early intervention, patient risk stratification, selection of therapy, and determination of the treatment duration. These are the 4 things which are important in the management of the PE. To approach to a patient of suspected PE, risk stratification is important, as I already mentioned. Look at the presence of the hemodynamic stability. Look at the clinical parameters and comorbidities. Look at the right ventricular dysfunction on the transthoracic echocardiography, and the CT pulmonary angiography is one of the most important investigations, and looking at the cardiac troponin levels. Then, what is the hemodynamic stability? The cardiac arrest has been one of the significant finding in the patient, those who are having a massive pulmonary embolism, and they require CPR. There is an obstructive shock where the systolic blood pressure falls below 90 millimeter mercury. Vasopressors are required to maintain blood pressure more than 90 plus and organ perfusion. There is a persistent hypotension. Patient with systolic blood pressure less than 90 millimeter of mercury or systolic drop of more than 40 millimeter of mercury than the usual pressure for more than 15 minutes. So there is a 40 millimeter drop for 15 minutes is also indicative of there is significant drop in the blood pressure. These definitions provide a standardized framework to identifying life-threatening hemodynamic states and guiding acute management. When looking at the clinical parameters, there is a pulmonary embolism severity score, and this has been one of the standard management of the patient of pulmonary embolism. Although it is a bit cumbersome, you can see here the lot of things are written, almost 11 parameters, but there has been simplified PACE, the simplified pulmonary embolism severity score. It is showing that age in more than, if it is 80 years, 1 point, 1 point for patient of the chronic heart failure, 1 point for the chronic pulmonary, and 1 point for the heart rate more than 110 per beat per minute, and systolic blood pressure less than 90, 1 point, and the arterial hypoxia less than 90% of the saturation, 1 point each. If any patient is having 1 or more, there is a patient is having a severe risk of having hypoxia and other cardiovascular morbidity and mortality. There is a 30-day mortality rated to be around 10.9%, which is very high. While in the standard PACE, means the pulmonary embolism severity score, the score grade class 3 to class 5 has a very high mortality. In the class 5, it is around 10%, and which is significantly high. So, to say that simplified PACE is much easier to use at bedside, I suggest that everybody should use this one only, and rather than using the standard the PACE, the pulmonary embolism severity score. So this is how we are using. And again, you have to just select the basically the parameters like age, male sex, chronic lung disease, pulse, systolic blood pressure, and oxygen saturation to calculate the PACE score. Then coming to the right ventricular dysfunction and transthoracic echocardiography. The Risk stratification, that this right ventricular dysfunction assessment by doing the echo is very important, and it can be done very easily bedside. And if the patient, you are suspecting D-dimer is high, clinical suspicion is very strong, and other tests are negative, then you have to go for the CTPA, CT pulmonary angiography. And then you can confirm whether you are dealing with the patient of pulmonary embolism or not. You have to also look at the troponin levels. 30 to 60% of the patients have acute pulmonary embolism have high troponin levels. Prospective multicenter cohort of this 5 to 26 normotensive patients were studied, and they found that high sensitivity trop-T, concentration less than 14 picogram per ml, had a very high negative predictive value of 98% in ruling out the patient with the PE, along with other factors. Age-adjusted high-sensitivity troponin T values less than 14 picogram per ml for patient aged less than 75 years of age. While if it is more than 75, this value may go up to 45 picogram per ml. Then coming to the classification of PE severity and the risk of early death. This slide is very important, and you should focus on it. Actually, looking at the early mortality risk, which is very high, when the patient is having hemodynamic instability, clinical parameters of PE severity and or comorbidity, PACE class 3 to 5 or simplified PACE more than 1, right ventricular dysfunction on transthoracic echo or the CT pulmonary angiography, it is positive, and elevated cardiac troponin is also positive. So the early mortality risk is very, very high in these subgroup of patients. When the patients have no hemodynamic instability, but other features are positive, then it is the intermediate high-risk patient. When the hemodynamic stability is not there, and clinical parameter is positive, and right ventricular dysfunction or the elevated cardiac troponin, either only one of them is positive or none of the positive, the intermediate low. While all other factors, if it is negative, then it is the low mortality risk on the patient of the pulmonary embolism. This is a flow chart actually how to follow these patients. Suspected PE in a patient with hemodynamic instability. You have to do the bedside transthoracic echo, look at the RV dysfunction. If it is not, probably search for other causes of shock or instability in this patient. It may not be the patient of pulmonary embolism. If it is yes, look at the CTPA immediately if it is available and it is accessible to you. And if this is not accessible, start the treatment of the high-risk PE. If the clinical suspicion is strong, patient is hemodynamically unstable, you should start with the treatment if the facility for the CTPA is not there. If it is there, go for the CTPA. If it is positive, treat it as a high-risk PE. If it is negative, search for other cause for the instability in these patients. So then how to treat high-risk patient? Look at the hemodynamics and the respiratory support, use the initial anticoagulation, and start the reperfusion therapy as early as possible. Hemodynamic and respiratory support is done by the advanced life support in the cardiac arrest and oxygen therapy, ventilation, and treatment of the acute right heart failure. Then coming to the initial anticoagulation. For initial anticoagulation, we have various drugs, the parenteral drugs and the oral ones. In the parenteral, there are indirect thrombin inhibitors like heparin, low molecular weight heparin, fondaparinux. There is direct thrombin inhibitors like leperidine, bivalirudin, and argatroban. In the oral, it is the vitamin K antagonists like the warfarin, the direct 10A inhibitors like the rivaroxaban, apixaban, and the edoxaban, and the direct thrombin inhibitors, it is the dabigatran or the etixalate. So these are the drugs actually which are available for the anticoagulation in this patient, and the most commonly used is the low molecular weight heparin in the clinical practice by most of us. Low molecular weight heparin, here in this trial actually they have used enoxaparin in comparison to the unfractionated heparin in the patient with the massive pulmonary embolism. And what they found? There was a less all-cause 30 days death in enoxaparin patients in comparison to the unfractionated heparin, and thus a less major and minor hemorrhage in enoxaparin treated patients. So it was clinically proven to be better in safety and in efficacy in patients with the PE. Now coming to the derivatives of heparin. As I have mentioned, the low molecular weight heparin is the choice because of the longer half-life and ease of use, ability to consistently achieve the therapeutic levels. There is no need to monitor the anticoagulant effects. Actually, you do not need to go for the PTINR repeatedly. It reduces the incidence of major bleeding complications. Various derivatives of heparin are there. I will not go into the detail. Actually, this enoxaparin, the dose is 1 milligram per kg every 12 hours. And tinzaparin we are not using. Deltaparin 100 IU per kg, it is twice daily, not the once. Sorry for this wrongly reporting. And fondaparinux we are using the 5 milligram for less than 50 kg of body weight, once daily, 7.5 for 50 to 100 kg body weight. It is the dose, OD dose is given. Then coming to the vitamin K antagonist. When VKs are used, the anticoagulation with unfractionated heparin, low molecular weight heparin or fondaparinux should be continued in parallel with the oral anticoagulant for more than 5 days and until the international normalized ratio INR value has been 2 to 3 for at least 2 consecutive days. So, with the start of the oral anticoagulant, you have to continue with the parenteral one for 5 days just to monitor INR, and once it is 2 to 3, then you can switch the parenteral and you continue with the oral anticoagulant. And the warfarin is started at a dose of 10 milligram in younger, aged less than 60 years, otherwise healthy patients, and at a dose of less than 5 in the older patient. The daily dose is adjusted according to the INR over the next 5 to 7 days, aiming INR level 2 to 3. That is how. With the availability of the NOACs, actually, things has become much easier to manage in this subgroup of patients. Then there are various varieties of drugs are available, the apixaban, the dabigatran, the edoxaban, and the rivaroxaban. These are the drugs which are available in the Indian market, and you can use this according to your choice and depending upon the patient's quality and what type of patient you are dealing with. Then coming to the reperfusion therapy. In the reperfusion, there are 4 things actually: the systemic thrombolysis, percutaneous catheter-directed treatment, and surgical embolectomy and vena cava filters. For the massive pulmonary embolism, these are the things which you are using for the reperfusion of the patient. Systemic thrombolysis, actually, the greatest benefit is when it is initiated within the 48 hours. One meta-analysis by Marty et al. Has shown there is significant reduction in the combined outcome in mortality and the recurrent PE, but there are 9.9% rate of severe bleeding and 1.7% rate of intracranial hemorrhage. Pulmonary thrombolysis trial has shown there is significant reduction in the risk of hemodynamic decompensation or collapse with the use of thrombolysis. And here we are using the RTPA or LT-place for this purpose in our clinical practice, although streptokinase and urokinase can also be used. Lytics are ineffective in chronic clot, limiting the efficacy and leaving the clot behind. How quickly does the clot become chronic? The fibrin-dominant thrombus only persists for 5 to 7 days. At 7 days, the 20% collagen is there, and for 21 days, it is 80% collagen. So practically, it is non-absorbable, and rather it cannot be lysed. So you have to use thrombolytic early. Best would be within 48 hours. And these are the fibrinolytic agents. The RTPA, basically the LT-place, the 100 milligram over 2 hours, 0.6 milligram per kg over 15 minutes has to be given initially and followed by the rest of the drug in the 2 hours. The streptokinase you use 2.5 lakh loading dose over 30 minutes and followed by 1 lakh unit per hour for 12 to 24 hours. Accelerated regimen is also being used when the patient is very, very sick and you don't have time. You just use this accelerated regimen, 1 million IU over 2 hours. In the urokinase, the 4400 IU per kg loading dose over 10 minutes, followed by 4400 IU per hour over 12 to 24 hours. Here again, the accelerated regimen has also been suggested that 3 million IU over 2 hours can also be used. Contraindication to fibrinolytics should be known. That is very important while you are using this drug. The absolute contraindication is History of hemorrhagic stroke or stroke of unknown origin. Ischemic stroke in the previous 6 months, central nervous system, neoplasm, major trauma surgery or head injury in the previous 3 weeks, bleeding diathesis, active bleeding. These are the absolute contraindication. Everybody should know this. The relative is transient ischemic attack in previous 6 months, pregnancy for first postpartum week, non-compressible puncture sites, traumatic resuscitation, refractory hypertension, systolic blood pressure more than 180, and active peptic ulcer. These are the relative contraindication. Now coming to the catheter-based therapies. Various therapies have been evolved, although it is not available at every place. Only occasional places might be having this facility. The catheter, the peripheral balloon, the catheter-directed fibrinolysis, ultrasound, accelerated thrombolysis, various other things are available just for the catheter guided therapy for the lysis of the clot or the emboli. So again, just there are a few things which are very important actually. The catheter-directed thrombolysis, ultrasound-assisted catheter-directed thrombolysis, a rheolytic thrombectomy plus catheter-directed thrombolysis are in clinical practice at the centers, those who are having this facility. One is the ultrasound-assisted thrombolysis, the ECOS system is there, and people are using just to removing the clot from the patient of pulmonary embolism. Another is the penumbra device for the aspiration and suction of the designed for removing thrombi in the pulmonary embolism and the deep vein thrombosis, and this device has been used successfully, having very good results. Float reverse system has also been used. The large bore catheters for the large clot halls designed to extract large volume of clot. Blood clot can be returned from by the flow with the flow saver. Actually, you retrieve the blood. It is a single session therapy. A lytic-free approach is there, and you avoided the ICU stay. And the rapid relief in the symptoms is there. But only thing is that these facilities are not there at most of the places. But you should know exactly these things do exist in the management of the pulmonary embolism. What the guidelines say for this? Basically, the European Society guidelines, which was last updated in 2019, they have placed it very high. Actually, rescue thrombolytic therapy is recommended for patients who deteriorate hemodynamically, and this level of recommendation has become 1 in 2019. The surgical embolectomy or the catheter-directed treatment should be considered as an alternative to rescue thrombolytic therapy for patients who deteriorate hemodynamically, and recommendation is 2A. Further evaluation may be considered for asymptomatic PE survivor at increased risk of CTEPH is also 2A. So these basically recommendation has moved up, and catheter-directed therapy and thrombolysis has to be, either of them can be used in this patient of massive pulmonary embolism at the earliest, which is a lifesaver for these patients. Surgical embolectomy, although it is also very not available at very often, and here the surgeon has to take the do the cardiopulmonary bypass, cardioplegic cardiac arrest is required, then incision of the main pulmonary artery and removal of suction of the clots is done. By this, you remove the clots from the system. Then use of vena cava filters. It mechanically prevents the venous clots from reaching from the pulmonary to the pulmonary circulation. And while it is not a first choice to have inferior vena cava filter, only the few indications are there when there is absolute contraindication to the anticoagulant treatment in the patient with the PE. Recurrent PE, despite adequate anticoagulation, then you can use this inferior vena cava filter. And the primary prophylaxis in patient with a high risk of VTE, then you use this one. And there has been trial which has shown that it has got a very good result. In patient of suspected high-risk PE, administered heparin, start with 80 IU per kg IV, then do the ECG, do the echocardiography, give the oxygen, ringer lactate or normal saline, use inotropes and vasopressors. If necessary, intubate and do the mechanical ventilation. After initial stabilization, if it is there, then confirm with the CTPA, use the reperfusion therapy. If it is not done, ECMO should be initiated in these patients. Patient is not stabilized, you can start ECMO, and then do the CTPA, do the reperfusion therapy. And if ECMO is initiated or absolute contraindication to thrombolytic treatment, then surgical or catheter embolectomy may be done in these patients. If it is not, there is no contraindication, go for the thrombolysis. This is how you manage these patients. Then coming to the patient without hemodynamic instability. Assess clinical probability of PE, low or intermediate clinical probability of PE unlikely, do the D-dimer test. If it is negative, no treatment is required. If it is positive, go for the CTPA, and if PE is positive and CTPA confirms it, to start treatment. If it is not, then no treatment is required. There's high clinical probability of PE is likely. Then go for the CTPA, and if the no PE, no treatment is required, the PE confirmed, start with the treatment for the pulmonary embolism. Then treatment of intermediate risk embolism is the hospitalization. Patient with the signs of RV dysfunction should be monitored over for 3 to 4 hours or days due to the risk of early hemodynamic decompensation or the circulatory collapse. Routine primary reperfusion treatment, notably fully dosed systemic thrombolysis, is not recommended in this subgroup of patients. This thing should be known to everybody. So this is all already I have mentioned. Chronic treatment and prevention of recurrence. Patient with PE be given anticoagulant for at least 3 months. Extended anticoagulation can reduce risk of recurrent VTE for more than 90%, but there is an increased risk of bleeding. There is a specific situation, I think, slide is not moving. Yeah. So there are definite situations like cancer. Patient with acute PE and cancer, particularly those with GI cancer, should be encouraged to continue low molecular weight heparin for more than 3 to 6 months. In patient with anticipated low risk of bleeding and without GI tumors, the choice between LMWH and rivaroxaban is left to the discretion of the physician and the patient preference. However, the oral therapy would be preferred in this subgroup of patient. Now coming to the special situation of pregnancy. Suspected PE during pregnancy, high pretest probability or intermediate, low probability or the positive D-dimer test. Then start anticoagulation with the low molecular weight heparin, do the chest X-ray, compression, proximal duplex ultrasound if symptoms or signs of suggestive or DVT is there. If proximal DVT is present, continue with the low molecular weight heparin at therapeutic dose, assess PE severity and the risk of early death, refer to the multidisciplinary team with experience in the PE management in pregnancy, and provide plan to guide management of pregnancy, labor, and delivery, postnatal and the future care. So you have to be very cautious that you have to develop a team so that those who can look after these type of patients. If it is not there, proximal DVT is not present, then a specific investigation is done like CTPA or the perfusion lung scan, and then if chest X-ray is normal, then you can skip this, and indeterminate or positive, probably you have to review it again and start treatment. Just I will be finishing in few minutes. And this is a very simplified slide for the years protocol actually in the pregnancy, and this slide I have borrowed from Dr. A.K. Singh actually. The very simple thing that in the clinical criteria, clinical signs of DVT, if it is present, hemoptysis is there, and PE is the most likely diagnosis. There are 3 things. Then step 2 is to do the D-dimer test. If zero criteria and D-dimer is less than 1000, then VTE is ruled out. If more than 1 criteria and P is less than 500, then thromboembolism is ruled out. If D-dimer is more than 1000, and then go for the CTPA. If D-dimer is more than 500 and any criteria is present, then it is positive and you should go for the CTPA. If clinical signs of DVT, perform compression ultrasound of symptomatic leg if it is there. If there is swelling in any limb, then you should go for this. Abnormal cus, initiate anticoagulant. If it is normal, continue the D-dimer pathway and look at the other factors. In the acute PE and active bleeding, inferior vena cava filter has to be done. And anticoagulation in young women on oral contraceptive pills, the OCP has to be stopped and go to the alternative method of contraception and continue with the therapy. Chronic thromboembolic pulmonary hypertension, there is around 3.5 to 3.8% after the initial episode of PE and 13.4% after the recurrent PE. I will not go into the detail. Actually, just basically for the management of CTEPH, pulmonary thromboendarterectomy is the answer. Other treatment option is the balloon angioplasty and the pharmacological management. There has been various protocol. I will not go into the red detail. The oral drug, the Riociguat, is one of the treatment of choice for the patient of chronic, the CTEPH, chronic thromboembolic pulmonary hypertension. You can use it. The dosing for all these anticoagulants is given here. The enoxaparin 1 mg per kg BD subcutaneously, deltaparin 100 units per kg BD, unfractionated heparin 100 units per kg stat, then 1000 units per kg stat, then 1000 units per hour, and fondaparinux 7.5 milligrams subcutaneously daily. So all these drugs, actually rivaroxaban 15 mg BD for 3 weeks, followed by 20 mg OD. It is OD here, sorry, it is wrongly mentioned. Apixaban 10 mg BD for 1 week, followed by 5 mg BD. And dabigatran has to be used at 150 milligram BD, preceded by the therapeutic low molecular weight heparin. This is what the dosing had been. So with these words, I like to thank all of you for the patient hearing. Thank you.
Hello. Thank you, sir. For a wonderful talk on pulmonary embolism, and you have covered it so comprehensively. I think no question will be remaining there. And on behalf of Allahabad Medical Association, and particularly Dr. Ashutosh Gupta, I would like to congratulate you and say happy birthday.
All right. Thank you. Thank you.